Now live.
Oh my goodness, it's happening. Okay, welcome everybody. Yay, that's good. Who wants to start on time? I'm gonna be fashionably late. That's the way life rolls, right? We roll with it. It is so nice to see everybody here live in person, so welcome. And my name is Belzer. I will be your host and MC for tonight. For the Q&A panel and on the women's heart and brain health, which we have this lovely panel of guests for. Tonight we begin by acknowledging that the land on which we gather is the unceded territory of the Coast Salish peoples, including the territories of Musqueam, Squamish, and Tsleil-Waututh nations. On behalf of the event organizers, I'd like to extend a heartfelt thanks to KPMG for providing us with this beautiful space this evening, and the Heart and Stroke for your generous help and funding to make this event happen. Big thank you as well to the Canadian Women's Heart Health Alliance for establishing Wear Red Canada and facilitating the promotion and live streaming of this event this evening. Thank you to our principal event organizer, Emily. She's over here. Yeah. We love you, Emily. It's okay. The live stream's up. You're good. You're good. Emily is at the Leslie Diamond Women's Heart Health Clinic, and all the amazing volunteers. Also, big thank you to all of you as well for making the event work out tonight with all the behind-the-scenes organization. So thank you. And now it's my pleasure to introduce Robin Jones-Murrow, Heart and Stroke Senior Vice President for Western Canada, to say a few words. Thank you.
Good evening, everyone. I have the honor of bringing welcome greetings from Heart and Stroke. It's so great to be here and look out at the sea of red. Thank you for being here tonight. Women's heart and brain health is such an important issue. In my interaction with the community here in Vancouver and across the Western provinces, I speak to people about Heart and Stroke's commitment to women's health. And I'm struck by how often I hear their stories of their mother whose signs of a heart attack went undiagnosed, of their sister who put aside her signs of her heart attack because she was too busy looking after her children and aging parents. This is an issue that affects all of us. And the time has come for us to dig in, tackle the gaps in diagnosis, treatment, and care for women who are living with heart disease and stroke. Heart and Stroke's vision is to live in a world where all women receive the care they need when it comes to their heart and brain health. Achieving this vision will be a massive collaborative effort, working with partners from all sectors where we work to drive change in 3 key areas: funding more research focused on women, raising awareness of women's unique signs, symptoms, and risks, and driving efforts to transform our health systems to improve how heart and brain care is delivered for women. We are so proud to partner today with the Leslie Diamond's Women's Heart Health Clinic and the Canadian Women's Heart Health Centre. I'd also like to acknowledge our friends at VGH Foundation, who are fantastic partners in our work. Tonight, our MC Amber will walk you through how to submit your questions to the panelists via Slido, so please ask away. We'll kick off the conversation now this evening, but I hope you'll continue to speak with your family, your friends, and your colleagues to help us raise awareness. And don't forget to take your photos and post on social with the hashtag #HerHeartMatters and Wear Red Canada. Thank you to KPMG for providing this beautiful space, to our panelists, our moderator, and to the team of volunteers who have put this event together tonight. Enjoy, and let's get talking.
Thank you, Robin. Thank you to everyone for coming tonight. And if you haven't already, panel, get your microphones on. Someone's getting a call. Someone's getting a call. Thank you, everyone, for coming tonight to learn more from our expert panel on the challenges that face women today in regarding our heart and brain health. For years, people considered heart disease and stroke to be a men's disease. Research based on the assumption that what worked for a man would work for a woman. But women are not small men. We're way different in so many ways. And not researching the difference is unfortunately proving fatal for women. So we all have women in our lives from whom we love, our mothers, sisters, daughters, friends, and we're losing too many of them too soon and unnecessarily. It's up to all of us, the researchers, the healthcare professionals, policymakers, people living with heart disease and stroke, the public, and everyone in this room today, and those joining us virtually, to help support and help correct this inequality. So thank you for your attention, and more importantly, your interest this evening. Before we begin, a couple of housekeeping things, because there always is stuff for you to be reminded of. First of all, thank you for all the people joining us on Facebook Live, and we want to hear from you as well about this very important topic. We're glad we can share beyond this room, but so happy that everyone is joining us in both ways. In a minute, we're going to introduce our panel, and I have some questions that are going to get us started, but as Robin mentioned, we have a way for you to submit your own questions. It's slido.com. So on your phones, if you go to slido.com, you can enter the code 2023 VAN WRC, and then you can submit your questions. The way it works is you put your question and everyone can vote on which questions we want answers for. So if you don't have a phone with you or don't want to do it online, you can raise your hand. One of our volunteers will come, get your question, write it down, and our lovely Emily will put it in the system for you. So there are ways to do it, and that goes for everyone joining us virtually as well. Slido.com and enter your question. We'll get that discussion going later on. Also, registration, the volunteers gave you a short feedback form, and we hope you can do that survey and return it to the survey box at the registration code check area when you leave, because that feedback is instrumental in helping us decide how to do these events, what works, what you'd like to see more of. So please do give us your feedback. We really do appreciate it. Without further ado, let's join our lovely panel here. We have Dr. Sedlak. She's a cardiologist at Vancouver General Hospital, a clinical associate professor at the University of British Columbia, and the medical director of the Leslie Diamond Women's Heart Clinic. Dr. Zhou is a stroke neurologist at Vancouver General Hospital and UBC assistant professor in the Faculty of Medicine Division of Neurology. Dr. Zhou's research focuses on population health and stroke epidemiology. We also have Mahraz Parvand, an avid researcher of women's cardiovascular health. She's completed her Master's of Science at UBC in experimental medicine in 2018 and is currently a UBC third-year medical student. She continues to work with Dr. Sedlak's team to help improve women's health. We also have two women with us this evening to share their lived experiences with heart disease and stroke. Aviva is a dietitian, and she was diagnosed with a stroke in 2019 and enjoys being outside nature, trying new recipes, and patient advocacy. Next to her, down in the middle, we have Kelly. She's a retired teacher who lives on Vancouver Island. She was diagnosed with coronary microvascular disease in 2018 and has been involved in various social media advocacy groups for women's heart health ever since. Thank you all for joining us today. I will be inviting our Aviva and Dr. Zhou to share their stories and perspectives about stroke and brain health tonight. So, Aviva, Your experience with stroke happened when you were quite young. We talked about this earlier, very young. Can you tell us more about your experience getting diagnosed and navigating the healthcare system in the years since?
Yeah, of course, I'd be happy to. So I had my stroke when I was 27 years old back in 2019. And I'll just set this stage to give you an idea of what it was like when it happened. So I remember I was sitting at my laptop computer trying to buy an Uber Eats gift card for a friend who I was visiting later that day who had just had a baby. And I remember sitting at my computer knowing what I had to do, but not being able to actually perform that task. And I'm so grateful that I was at home with my mom when this happened. And she approached me and she said, "You've been sitting there a long time. What's going on? What are you trying to do?" And you said, I have to do this thing. And my mom said, "Okay, what thing?" And I said, the thing that you do for people who have babies. And I just couldn't get the words across of what I wanted to do. And at that point, I think I wasn't even sure what I was trying to do. So I told my mom, I could see in her face that she was starting to panic a little. And I said, "I'm fine, I'll just have a glass of water and I'll be okay." And my mom said, "Okay, I'm gonna get in the shower and then we're gonna go to the hospital. I think you're having a stroke."
Wow.
And me at 27, one, I didn't think that I could have a stroke at the age of 27, and two, I didn't understand what was happening to me. In my mind, I thought I was gonna be okay. I didn't really realize that I couldn't communicate properly. And that's kind of the blessing of having that area of your brain affected, is that you're not fully able to comprehend what's happening to you. So during my whole treatment that I received at GF Strong and at VGH, first at VGH, sorry, I made a small mistake with my words, and that's one of the, small deficits that I still have from my stroke. But my mom took me to VGH. I was seen almost immediately within the CT machine within minutes of arriving. And I'm so grateful for all of the care that I received by the stroke unit and all of the doctors, nurses, and care team at Vancouver General. That was pretty much what happened to me through the diagnosis. I stayed at VGH for about 2 weeks. And from there I went to GF Strong, where I received a lot of therapy. I worked with a full team of speech language pathologists, occupational therapists, who helped me recover my ability to speak and understand language, which was the main deficit. When I thought of stroke at that time, I always thought that it's about like a drooping of the face, because that was a lot of the signs I had seen on TV and commercials and advertisements, but I didn't realize that it can manifest in that way. And I'm really grateful that my mom knew the signs of stroke and she was able to recognize what was happening to me and took me to the right place. In terms of my recovery, as you can see, I've done pretty well. My team at VGH supported me. I went back to school to McGill to become a dietitian, and they were able to support me throughout that whole process. So I was really grateful for that as well.
Wonderful. Thank you, Aviva, for sharing your experience with us. I know it's scary to share, but not as scary as I'm sure that was at the time. Now, Dr. Zhou, I wonder how many experiences like Aviva's you come across in your practice. Can you tell us more about some of the sex and gender specific trends you've noticed with your patients?
Yeah, so women have different types of strokes during different parts of their lifetime. In general, strokes come in two big flavors. There's ischemic stroke, where there's not enough blood flow to the brain. And the typical cause for that is a blockage to one of the arteries in the brain. And then the other type of major stroke that you can have is hemorrhagic stroke, where there's bleeding inside of the brain, and that might be from a burst artery. For younger women, a part of my research specifically actually focuses on a more rare cause of stroke that can lead to either, where you can have a blockage in one of the veins that drain the head, and that could lead to ischemic stroke or hemorrhagic stroke. And in women, at different parts in their lifetime, they can have rarer causes of stroke, like blockages in the vein, or because of constriction of arteries inside of the brain. And a lot of these factors really fluctuate during a patient's lifetime. I think something that's really important also, like Aviva's experience, is that some of these rare types of stroke can present with very different symptoms than the ones that we're used to. For example, one of the cardinal signs of a blockage in one of the veins is actually a really terrible sudden headache. And that's also one of the presenting symptoms of spasms of artery inside of the head as well. And that's really not a typical symptom that people think of with stroke. Some other things can be more non-specific as well, like visual blurring or double vision, or even patients can initially present with seizure in these special types of circumstances. And so that's why it's really important that we study different causes of stroke all throughout a woman's lifespan.
Excellent. Thank you, Dr. Zhou, for teaching us more about women's stroke symptoms and considerations when interpreting stroke-like symptoms. Definitely important for us to raise awareness of these differences. Kelly, similar to Aviva, you also had an atypical experience with your heart when you were younger. Can you tell us your journey up to getting your diagnosis and how things have been since?
Thank you. Yes, so my story, the heart event that I had, the heart attack I had, occurred in December 2017, but I need to go back further to that to fill in the details. I had been seeking help from my doctors for a couple of years preceding that. I wasn't feeling well, things were changing. The heart event happened when I was 49, just 3 weeks before my 50th birthday. And I would say by the time I was around 45, things were just not right. I was a really active person, extremely active all my life. I was a really engaged teacher, passionate, committed, loved teaching, still do. And I was looking for answers. I realized after I had the heart attack that I certainly had been experiencing symptoms before that. My GP refused to refer me to a cardiologist. An endocrinologist that had diagnosed me with hyperthyroidism that year refused to send me to a cardiologist. Despite my family history and whatnot, I guess my symptoms just didn't make sense to them and connect to my heart. So it all ended with a pretty serious heart event. I was teaching, presenting, and I felt very unwell that morning. A lot of stress in my life at that time, and I had a migraine that morning, and I had suffered from migraines all my life. And I was teaching, and suddenly I had a sharp pain right here. And you know what you do when you have a sharp pain in your chest and you might be having a heart attack is you finish teaching. I finished the lesson. I didn't want to scare the kids. I didn't want to scare anyone, and I was scared too, I think. So I did that, but even better than that, you should also do your laundry, make a meal for yourself. Didn't go to the hospital until Saturday night, so it was Friday morning to Saturday night. I had different symptoms, like some really terrible indigestion, and I thought, must be indigestion. I sure hope it is. And continued symptoms I had had for months. My arm hurt, back, shoulder, blade, hurt, but I thought that was from sport, you know, but I knew when the symptoms returned, but worse, on Saturday evening, I drove myself to the hospital because, of course, that's also what you do. They admitted me immediately. I was presenting with a really typical heart attack. So I was in within minutes, and I have to give high praise to Eagle Ridge Tertiary Hospital. They did a great job. It did take 5 days for me to get an angiogram. That's a long time if you're presenting with a serious heart, what looks like a typical MI. It turned out to be a stress cardiomyopathy, and that should have been great news because my arteries were clear, absolutely pristine, as the interventionist said in the room at the time, and I was so relieved. And he said, but you've got, your heart is partly stunned, it's not working properly, but you're gonna be great. In probably a month, you'll be 100%. And that definitely didn't happen. I continued with chest pain every single day from that day forward and that morning of teaching to today. I landed in Tara Sedlak's office. I researched it myself because the cardiologist really had no idea what to do with me, but he thought that it was syndrome X. He really was correct, but he didn't know what to do. So he sent me, referred me on to Tara. She knew exactly what to do. I remember our conversation, and I can imagine you just thought, wow, you're you're a typical case of microvascular syndrome or disease. So I had another angiogram, was properly diagnosed, properly treated, and have really stabilized since then. I feel like, is this still working? Yeah. Just to wrap up, what's life like now? It is not the same at all. I fought tooth and nail to hang on to teaching. I just dearly love that job, but I've finally given it up completely. It does not agree with me anymore. The emotional stress, the physical stress with the kids, it doesn't work. So I lost a lot. I cannot exercise in the same way at all, but I gained a lot. I have, I think, a better quality of life because I really understand what's most important, and the quality of my relationships is number one, and taking care of myself. That's been a battle. You know, they say women don't give themselves permission to really take care of themselves, and I would have thought of myself as someone who was maybe better at that, but I don't think so. So this year is my year. I've decided to turn complete attention to my health and wellness and see how much better, like maybe I could get a little better at least. But I hope to just live a whole bunch longer. And I'm really glad you're here because I think this is a big problem, women being turned away. I've seen my own sister be turned away in an ED by a cardiologist and basically tell her that she's just an anxious menopausal mess, essentially, right? And she turned out to have the same situation, has a very similar condition that I have. So it has to stop, and I don't know what would have happened. I'm glad I went to the hospital. I'm not sure what the outcome would have been if I hadn't. So we really have to support each other and spread the word. I always listen with interest when women tell me now that they're not feeling well. I'll always ask a few more questions because you never know, and I will always say, just go get it checked out. And if your doctor won't refer you, I say ditch that doctor. And also ditch that cardiologist because you won't change their minds. You can't. Like, that's impossible. So find someone who will listen. Yeah. And then also, if you have to go with someone to an appointment, go. Help her out. Whether it's an aunt, friend, sister. Yeah. Because it helps a lot. Because you feel crazy when you're in there. All right, that's it.
Thank you, Mary. Advocate for yourself, advocate for your girlfriends, all the women in your life. You gotta keep pushing when you know on a gut instinct level something's not right. So Dr. Sedlak, you are Kelly's cardiologist and expert in women's heart health, including the diagnosis Kelly has, which is called coronary microvascular disease. Show of hands, has anybody heard of that before? A few. I would say that's less than 10% of the people here today. So that means we need to learn more about this coronary microvascular disease. Could you help explain to us a bit about how this disease and other forms of women's heart health disease are different from the stereotypical chest-clenching Hollywood heart attack, and how symptoms and other heart risk factors are the same and different?
Sure. Thank you. Yeah, so I thought I'd start off by talking about symptoms because I think Kelly's story is classic in terms of, I can't tell you how many times, probably hundreds of times, where we made a definitive diagnosis of heart disease and their story was the same, where they got turned away. So, you know, at the end of the day, you know, the research will show that chest pain is still the #1 symptom of a heart attack in women. However, there are some differences. Certainly women can actually very much describe their chest pain differently. So they'll describe it as tightness or as a pressure, as opposed to the classic sort of elephant on the chest. And so, and then they can have a lot of referred symptoms. So I have a number of women in my practice who have no chest pain and only have jaw pain. And I can't tell you how many times they've been to their dentist, and their dentist is like, no, you do not have a dental problem. So jaw pain, arm pain, lots of referred pain, and then lots of symptoms to go along with it: shortness of breath, lightheadedness, dizziness, fainting, shortness of breath, fatigue. So there can be a lot of other symptoms that go along with pain, and we need to recognize that. And if something in the back of your head, like Kelly was saying, something in the back of your head is saying, geez, this doesn't feel right, keep pushing, because that's what we have to do. So that's the first thing. The second thing is risk factors. I just want to take a moment and talk about risk factors, because I think a lot of us feel as though, risk factors in women are the same as men. And in some degrees they are, and in many degrees they're not. So certainly things like smoking, diabetes, and high cholesterol and high blood pressure are risk factors in both. But actually some risk factors, like diabetes, I'm actually much more worried about a diabetic woman than I am about a diabetic man. And the research shows that women who are diabetic have 2 to 4-fold increased risk of developing heart disease than a man. Similar with smoking. And then women have sex-specific risk factors that I guarantee you most people are not asking about. I've asked my own colleagues, and I get sort of, 1% of the time they'll tell me that they're asking about them. And those are menopausal risk factors. So when did you go through menopause? How were your pregnancies? Did you have high-risk pregnancies? So high blood pressure, gestational diabetes. Did you have troubles with your menstrual periods when you were growing up? PCOS, polycystic ovarian syndrome. And were you on hormone replacement therapy? Were you on oral contraceptive therapy? Those are all very, very important things to ask about. And of course, we don't ask about those in men, and that's not the standard checklist that you're taught in medical school, and so it just is not asked. But at the end of the day, those risk factors add up, and they can be very important in sort of saying, okay, no, this is not a low-risk patient, even though they don't have the standard risk factors, they've got a lot of these other things, and they can be at higher risk. And then finally, the presentation and causes of heart disease in women can be quite different. Still, at the end of the day, women can develop the so-called, heart attack with the jammer, with the 100% blockage in the artery that we open up with a stent or we bypass. That is still very common. But women can have other presentations. So they can have a tear in the artery. So where the artery actually has a small tear in it. So it doesn't actually block per se, but it tears, and that's called a dissection. Spontaneous coronary dissection. That's much more common in women. You almost never see it in men. And it can be very difficult to diagnose. We're putting dye into an artery looking for a blockage. You don't see a blockage, you say it's normal when there's actually a little tear. It can be small vessel disease, so microvascular disease. So it's not the large blood vessels, it's actually the small blood vessels that are dysfunctional, the flow in them is abnormal, they can spasm, they can become blocked. And then you can have spasm of the arteries, where the artery literally starts off normal and then spasms down and then opens back up again. And if you don't catch it in the act, you can miss all of those types of syndromes. So we're trying to develop techniques like specialized angiograms, like what Kelly had, specialized MRIs, to try and diagnose some of these causes, which are much more difficult to see on a standard angiogram, even though that's the gold standard.
Great, thank you, Dr. Sedlak. Definitely highlighted a lot of important things that we need to consider as a community in watching out for ourselves and the women we care about in our lives. Mahraz, you worked with Dr. Sedlak 6 years prior to starting medical school and have been researching trends in women's heart disease in the specialized clinic over time. Can you tell us about your research and key findings?
Of course. So we developed a registry at the Women's Heart Center to see how well these women were doing, if our investigations were working well, and if we were treating these women appropriately. So we had our first study published in 2022. It was a prospective study, so over time we saw what women were doing from baseline to our 1-year prospective follow-up. And there were 3 specific results that I thought were relevant to this event that I wanted to share. One was that many of these women who were being referred to our clinic were being referred by other clinicians, other specialists, but they still didn't have a diagnosis, and to no surprise, they were not on appropriate treatments. So what we found is being placed at a multidisciplinary center, such as the Women's Heart Center, significantly increased the number of diagnoses that these women got, one of which was microvascular disease, which Dr. Sedlak spoke about. The second most common one was coronary vasospasms. And that's when your coronary spasm out of control and you therefore don't get blood flow to your heart and other organs, and therefore you get chest pain, as Dr. Sedlak discussed. The second thing that we found in our study, and that had already been shown in previous studies, was women with these 2 specific diagnoses, so vasospasms, microvascular disease, had a significantly lower quality of life, and also, as a result of that, had a significantly increased level of anxiety and depression. And we did surveys at baseline and at our 1-year follow-up, and we saw that attending a multidisciplinary center actually significantly improved the quality of life of these women and also significantly decreased their level of anxiety and depression. And, that could be due to different reasons. One is your risk factors, as Dr. Sedlak discussed, are being followed up by a multidisciplinary care team. Second is you finally have a diagnosis, and we talked about how you can feel like it's in your head. It's not. It's a physiological action that's actually happening, and that can calm you down because then you can get appropriate treatments that control, to a certain degree, your symptoms. The last thing that I wanted to mention is that we found that many of these women who didn't have a diagnosis prior to the heart center had to go to the emergency department quite often because, as you can imagine, you don't know what's happening, you continue having chest pain episodes, and you keep going for help. And many of them, after coming to a women's heart center, receiving a diagnosis, being put on appropriate treatments, on our 1-year follow-up had a significantly decreased number of emergency hospital visits. Now, as you can imagine, that's not only beneficial for the patient, so they don't have to go in all the time, but it's also very beneficial for healthcare costs because then we're decreasing the number of hospitalizations that we're having for angina. And with that, Amber, I'm going to pass it back to you.
Well, thank you, Mahraz. Those are some interesting findings you've highlighted about how a specialized clinic can help reduce anxiety and hospital visits. We hope more cardiologists will take note of what's being done here for the patients and for women in general. All right, so that's enough us talking at you. Now we're going to do interactions. So if you haven't already, you can check out slido.com and submit your questions. We do have a couple. I can see Emily frantically writing some down, but I've got some already prepared. So this is some interesting information that we're going to get for you guys. So if you have a question and you want one of the volunteers to get your question up to Emily, you can just raise your hand and we'll do that for you. So let's start off with Dr. Zhou. How do changes in hormones like estrogen affect brain health over our lifespan, like birth control, HRT, menopause, etc.?
Yeah, so a huge topic to unpack. So sex hormones, we know a lot about them on a basic science level that has a lot of relevance to cardiovascular disease. So in general, for example, at the platelet level, estrogen is thought to have some antiplatelet effects compared to testosterone. And then also for a very long time, we know that it helps increase autoregulation of cerebral vasculature. And that was the thought for why it seemed like stroke specifically had a lower age-adjusted sex and gender incidence until menopausal periods. And that actually led up to one of the biggest studies that we know of in women's health related to hormone replacement, the Women's Health Initiative. And that was really surprising. It found that when we supplemented in postmenopausal women who were given added estrogen, that there was actually a slight signal for increased stroke risk. And that was quite a surprising finding. And it illustrates the importance of doing randomized controlled trials and not just relying on basic pathophysiology and retrospective data. Also specifically about the use of hormonal contraceptives earlier in a patient's lifespan. We know that estrogen in general is associated with some risks of both clotting in the veins, like more common clots that we might run into are clotting in the legs or in the chest, and then less commonly, there is a slight association with increased stroke risk. And so that's always something that we're very aware of when we see young women who are on oral contraceptives, and especially if they have other risk factors. So for example, young women who are on hormonal contraceptives who also smoke, that makes us very worried. Young women who have migraine with aura, which means they have neurological symptoms with their headache. So they can have numbness or visual changes or even times speech changes. These patients being on oral contraceptives also makes us a bit more concerned. So, and then the last part is, of course, related to the pregnancy period. So Some of the highest risk periods during our lifetime, one of the highest periods is when you're a baby, and then one of the other higher risk periods is during childbearing years around the time of birth. So there's an increased risk of both ischemic stroke, which is the type of stroke that you can get when there's not enough oxygen, as well as bleeding. And so that's why there are certain factors that we monitor quite closely during pregnancy, like blood pressure, sugars, as well as even presence of proteins in the urine.
Excellent, thank you. And like Dr. Sedlak said, diabetes as well, which gestational diabetes is a big risk for sure. So Dr. Sedlak, how does COVID affect the heart?
Yeah, great question. I think COVID has really opened our eyes to a lot of cardiac effects that have actually been around for a while to some degree with other viruses, but now it's really highlighted a number of them. So first of all, COVID and other viruses can cause an inflammatory condition, and that's called myocarditis or pericarditis. So where you have an inflamed heart, you can have inflamed the sac surrounding the heart, or you can actually inflame the heart itself. And so that can be certainly an outcome of COVID. Certainly in the beginning stages of COVID, we know that there were a lot of cardiovascular effects in terms of clotting. So people were at higher risk of heart attacks, they were having strokes, they were having micro clots inside their heart. And then the other thing that's really come out with COVID is long COVID, and long COVID does have effects on the heart. And in particular, we call this something called dysautonomia. And what that means is that your autonomic nervous system, which sort of controls your heart rate and your blood pressure, and it's your sympathetic nervous system, which is your fight or flight, and your parasympathetic nervous system, which calms everything down. And if all of that gets really out of whack, so to speak, then your heart rate's too high, your blood pressure's too low, and you faint a lot of the time, and you don't feel well. And some people with long COVID have ended up with this dysautonomia. And it turns out that that's not new to the world. Dysautonomia has been around for a long time, but it's been understudied for sure. And now I think with COVID, it's really highlighted a condition that's been around for a long time, and I'm hoping it's going to lead to a lot of research for people that have just really not been treated properly in the past.
Thank you. Next question is for Kelly and Aviva. You can take turns, I guess, answering. How has your stress levels affected your heart and brain health before and after your event? I know Kelly already touched on this a little bit, but perhaps you can answer, Aviva.
Yeah, thank you for the question.
Yeah, it is.
Similar to actually what Kelly spoke to, I think one of the biggest ways that stress has changed before my stroke and after my stroke is listening to my body and paying attention to what my body is telling me. Like I said, I was 27 when I had my stroke, and I was working 2 jobs at the time, and I did have headaches for a while leading up to it, but you think that the headache, you're 27, it was this summer, I'm dehydrated maybe, I'm working too much, I haven't slept enough, my run was too long, all of these things kind of come into play, and I think I was under a lot of stress and putting a lot of pressure on myself. Like Kelly said, I think as women, we tend to do that. So I think now, like Kelly said too, I've been given a gift where I've been able to reassess what's important to me, what my values are, and kind of pay attention to my stress levels and really keep them low. And that's actually like a really great gift that I was given.
Yeah, it's on again. I totally agree. Stress is quite the enemy now for me. It's terrible, but if I watch something too stressful on TV, I may get chest pain. So I have to, just have to keep life easy. Try to keep it easy. Yeah.
Excellent, thank you. I've got a question that was submitted on Slido. What's the difference between non-traditional symptoms of heart-brain disease and traditional, like exercise intolerance, palpitations, fatigue, memory loss, anything like that?
Yeah, I can take that. I mean, so certainly, we know that women have more non-traditional symptoms. I like the fact that whoever submitted the question said non-traditional symptoms. What I do not like anymore is the word atypical. We're trying to get away from that word because what's atypical for one group of people is actually classic or typical for somebody else. So we're trying to get away from that verbiage. So yeah, non-traditional symptoms would be, shortness of breath, would be fatigue, would be palpitations, and all these need to be investigated. And if it turns out at the end of the day that it's benign palpitations and skipped beats that all of us can get once in a while, or that it's fatigue from, who knows, stress or working too hard, great. But at the end of the day, these types of things need to be investigated, and it's not just sort of classic chest pain that we need to pay attention to, because I think we're missing a lot of heart disease if we just focus on that.
Great, thank you. Mahraz, do you think that the trends from the research you've seen would also apply to people of color, those who are underrepresented, not presented in many heart disease research studies? Because I know that typically in the past, most research has been done mostly on men.
That's a great question, Amber, and I hope I had a definitive answer for it. Our study, we had majority of our participants being Caucasian women, and I feel like one reason for that is because we're more in the Vancouver urban area. If I were to, take an educational guess, I would say we would have similar investigations and similar diagnoses for women of different backgrounds and ethnicities. One thing that's very different that Dr. Sedlak is touching on is the different risk factors in women with different backgrounds. To give you an example, we know from previous research that African American women, Indigenous women have a much higher rate of hypertension or high blood pressure and diabetes, which makes it even more important that they do have access to these women's heart centers. So one thing that we're currently brainstorming and doing is thinking of ways that we can increase accessibility of our women's heart center to women from different backgrounds.
Wonderful. Dr. Zhou, I've got a question here that says, does the history of migraine increase your risk of stroke? Should drugs, I can't even pronounce that one, be lowered or increased by age?
So kind of a two-parter. So I'll start tackling the first one. So I think we're still learning a lot about the underlying pathophysiology of migraine. Specifically, about a third of migraine patients can have aura, and that's not just the pain associated with the migraine, but a specific neurological syndrome that can accompany the migraine. And sometimes it can be really scary. For example, a typical migraine aura might include like garbled speech, and that could be really similar to stroke. So I think it's really important, first of all, there's a little bit of uncertainty when clinicians are approaching patients with a history of migraine who have these symptoms, diagnose is this a migraine aura versus stroke. But we do know that in general, that is a risk factor for developing a ischemic stroke. So when patients have migraine with aura, there can be changes in terms of the reactivity of vasculature inside of their brain that can put them at high risk. So for example, we're at times a bit more reluctant, especially in the past when there's much higher doses of estrogen contained in older contraceptive medication, to use that in conjunction when a patient has a history of migraine with aura. So as a population level, I would say, yeah, there is an association with ischemic stroke and migraine, but overall, in young women, the baseline risk of ischemic stroke is relatively low. That factor alone, we know there's an association, but no, it's a lower association. And of course, tons of young women with migraines with aura never have a stroke. And then the second piece of that is, in general, of course, every time we prescribe medication, we think about everyone's risk factors. And certainly, when people are young, they have different stroke risk factors. And we're very cognizant, especially if it's a young patient who otherwise don't have our traditional vascular risk factors, and thinking about what other things we're able to reduce and why for this patient specifically, despite the fact that they're young, they're living a really healthy lifestyle, they don't smoke. Sorry, just getting over this cold. But what specifically we can do for the patient in front of us in terms of selecting the right dose of the medication, as well as really looking at some of the less common risk factors.
Oh, you're still good.
Yeah. I think.
It's working.
Yeah, okay. Yeah, so Great question, and then certainly, I think we're learning a lot more about some of the rarer causes of stroke in younger women, really similar in terms of heart and stroke reason. So, patients who have stroke because of connective tissue disease that cause tearing in an artery. It's a common cause of stroke in younger patients, in both men and women. In patients who have vessel spasms, and again, a more common cause of stroke in younger patients in general, and also in women related to fluctuations in sex hormones. And then lastly, strokes in terms of both hemorrhage and ischemia from clots in the veins of the head.
Great, thank you. Another question, this one, recently in the news about, we should all dial it back, is how concerned should we be about alcohol intake with relation to heart and stroke? Tara? Isn't red wine supposed to be good for us? I know, everything in moderation, right?
Yeah, I mean, I just had a glass of wine, so I guess I'm, that's one of my two I'm allowed in a week now. Things have really changed over time. I think it's a totality of health. I don't think it's just focused on heart health, why various bodies have recommended that we back off on alcohol intake. I think alcohol intake in larger amounts, there is an association with atrial fibrillation, which is a very common irregular fast heartbeat that can be associated with stroke and other underlying heart conditions, and you have to take a blood thinner for. There's also an association between higher levels of alcohol and cardiomyopathy, so where the heart actually doesn't pump well over time, and certainly we see a lot of that in cardiology. So there is a link, but it's certainly at the higher end of intake. I think in totality, I actually did a review on this many years ago, and at that time, my colleagues were laughing at me, but at that time, my review of the evidence was that a woman, and again, this is about body size and other factors, could have half a drink of alcohol per day over the, and then have that daily throughout the week, and a man could have 1 to 2 glasses. And that was actually came up with that. I reviewed the evidence over 10 years ago, so I'm actually not that surprised that they've backed off on it, just because of some of these effects. But I think, if in a week you have 3 to 4 glasses, I honestly don't think it's a big deal. But I think I'm glad that we're backing off on it, because I think there's a lot of other things associated with alcohol, like mental health, stress, and I think there's just a whole myriad of things that would go beyond the scope of today that is associated with alcohol.
Yeah, and I think specifically at the lower end, a lot of it is, considering all aspects of health. I know that at some of the recommendation changes were driven because of the higher cancer risks associated even at the lower end of intake as well, which is why that guideline got bumped a lot further down compared to the last sets that we were used to. But certainly, this previous thought about, a small amount being beneficial, I think there's still a bit of uncertainty, and a lot of recent data suggests that might have been related to people already starting to self-restrict in terms of, getting a sense of maybe they didn't have a diagnosis, but they just felt unwell. And they're like, maybe I don't feel like I should be having alcohol. And so certainly now we know that even on the lower end of the previous safe drinking guidelines, there were concerns about associated elevations in certain types of cancer risk. And that was a really important consideration in addition to heart and stroke health.
All right, I've got a question now for Mahraz. So it's about research. Has there been any research done on women with congenital heart disease and on an aging heart?
Dr. Sedlak?
Well, there has been. Unfortunately, it is a very specific field in cardiology. So we have some excellent cardiologists, of which we're not, who run the Patch Clinic, which is a congenital clinic out of St. Paul's. And they follow patients all the way from when they graduate from BC Children's Hospital up until a very older age, who've had actually really significant underlying heart conditions. So where arteries have been switched at birth and now we're switched back, or ventricles, like pumping chambers have not been formed. And actually, patients are doing very, very well. Like, it is incredible how well they are doing when they would have, many years ago passed away at a younger age. So that's really exciting. But beyond that, I think it's just beyond the scope of what we do in our clinic.
Fair enough. All right, Raz, I'm not letting you get away that easy. What do you recommend teasing apart fake news from good research findings? There's a lot out there and we're all having to sift through it all and make sense of it all. What are your suggestions?
I'm not dodging out this one, my microphone isn't working.
Is that you? Or am I?
Thank you. I recognize that's challenging. I would have some suggestions that I use for myself, for example. Number one is, if you find a research article, try to find some others that either agree or disagree with that. So don't look at one source only as your source of evidence. Number two, if you're looking at a news media, see what's being cited. Is it a primary article? Is it from a university? Is it a government statement? Where is that information coming from? Is it anecdotal? And based on that, try to think about how objective that research or that statement is. Third thing I would suggest is look at the date of the article that you're reading, especially in a field like cardiology. Research is always showing new evidence and new data, recommendations are always changing, so make sure you're keeping up to date. And at the end of the day, if you have any questions, if something's not clear, if the data and the evidence doesn't make sense, please do bring it up with your healthcare professional. They would be happy to talk you through it and kind of help you make sense of that. So those would be my recommendations. Thank you, sorry about that.
Thank you. All right, I have a question here that someone says, is stroke becoming more common in women? They say younger, but they said they had two friends in their 60s, so that is the younger side of older. Is it more common? I know we've got Aviva here who obviously was on the very young side of that, so what are your findings so far with the increase of younger stroke victims?
So a little bit more information about epidemiology in general. So we know that stroke, I'm a bit more familiar with stroke deaths. So definitely age-adjusted deaths have been decreasing for a very long time. And then it was more in the US data that information became a bit more clear that in young people around 2013, 2014, and also reflected to a lesser extent in Canadian data, there was more of an uptick in age-adjusted deaths in younger people in general. That seemed to affect men more than women, and because of the kind of more granular geographical data that's available through the CDC, it actually seemed to affect rural areas more than urban areas. And so there's a lot more research to be done to tease out exactly why that trend is happening. Certainly, one theory is that it seems to be happening in parts of the country, in the US at least, where there's also increases in terms of what are called deaths of despair. So higher drug overdoses and also deaths that are thought to be related to mental health. And so I don't think anyone knows quite yet what's accounting for that trend, and certainly we need to learn more to look at if the associations between the regional effects are really causing the trends that we're seeing.
All right, this one is about testing. So this is a question from Anonymous. If stress tests aren't as effective in diagnosis for women, can you tell us what tests we should be requesting?
Yeah, it's a great question. So herein lies the issue. Stress testing we know is not that accurate. We know that in total, it's probably about 60 to 70% accurate in women. So you're gonna miss it 30 to 40% of the time. So that's not great. Having said that, in some places it's the only thing you can do. So for example, if I'm taking a call from Whitehorse, Do I fly them all the way down for an angiogram? Certainly if it sounds serious, but can I put them on a treadmill and see, if they can go 12 minutes and have no symptoms and feel really well and have no fatigue? Maybe they still need some investigation, depending upon their symptoms, but you're not rushing them down for an angiogram. So I just wanted to say that about stress testing, that I don't think we should completely get rid of it because it's available, it's easy, it's cheap, and it does give you some prognostic value, meaning if you can go a long time on a treadmill test, you're going to live longer than somebody who falls off after a minute. Having said that, this accuracy has really become an issue. So for example, it depends on what you're looking for and what kinds of causes you're looking for. So if you're looking for blockages in the arteries, and the woman is telling you, and I can't tell you how many times this has come up, where they're telling you that they have classic angina, chest pain that sounds cardiac, and their stress test is completely normal. You got to move on. You got to visualize the arteries either through a CT scan of the arteries with dye, which we're doing very, very commonly, so commonly that the wait list has become ridiculous. Or you need to do something more invasive like an angiogram. What we're struggling with right now is how to diagnose some of these other causes. So small vessel disease, we would love it if you could do an MRI and that would tell you everything. And maybe we're getting there on a research basis, but not on a clinical basis. And so we're still diagnosing some people clinically and some people with an invasive angiogram where we actually go up in the small blood vessels, put a wire down and test the blood flow that way. Then the final thing to say is that we haven't touched on arrhythmias a lot, but arrhythmias are common. Atrial fibrillation is common, and there's a stroke risk associated with it, significant stroke risk associated with atrial fibrillation and irregular heartbeat. And we're now recognizing that, a 24-hour Holter, 24 hours out of your life that you're on a monitor, and 364 other days that you're not, chances are we're not going to catch it. So if patients are telling you, or you're telling your physician, I've got these palpitations, but I wore the Holter and I didn't capture it, don't just sort of stop there. We're kind of going on, we're making them, asking them to wear monitors for longer, several weeks sometimes. We're asking people sometimes to buy their own little devices called a cardio device that you can actually carry around in your pocket. It links up to your phone, you can put your hands on it and it can tell you whether or not you're in atrial fibrillation or not, or even, not that I'm advertising these, but devices like the Apple Watch can do that as well.
All right, thank you. Couple people have been asking, what are some of the other symptoms? We know about the FAST, the face, arm, speech, and time to get diagnosis for stroke. What are the less common stroke symptoms?
Yeah, what a great question. I think in general, a golden rule is that a lot of stroke symptoms happen suddenly. So something that we don't typically think of as a stroke symptom are sudden onset headaches. So for example, causes of tearing in an artery or a blockage in a major vein that drains blood from the head or vessel spasms can all cause unusual sudden onset headaches in a patient who otherwise doesn't really have a headache history. So that's a symptom that a lot of people don't think of as associated with stroke and might be one to consider in younger people especially. Other things are associated with vision changes. So people can have double vision, and that's a symptom that's quite unusual, but doesn't make the TV ad of what we typically think of. Other things are dizziness and walking challenges. It's really common for people, because these symptoms are not the poster symptoms of stroke, to say like, oh, maybe I'll sleep it off, I'll feel better in the morning. And that's actually the worst thing to do for stroke, because a lot of the treatments that we have to offer for stroke work much better the sooner you present to hospital. So you shouldn't wait to see if the symptoms go away if there's worry that someone around you is having a stroke or that you yourself is having a stroke. One of the best things you can do for them is to get people to the hospital as soon as possible.
A few of those symptoms sound a lot like migraine, which I know we've already touched on. What would you suggest is like the deciding moment when you need to decide you need to not just take that migraine medication, but you also need to follow it up with like, this doesn't feel right?
Yeah, it's tricky. So the first few times, so one of the things is definitely if the symptoms happen and they're similar over time, that gives people a lot of comfort. So a lot of patients, if you have a history of migraines, you get a sense of familiarity into what your headaches feel like and what those auras can feel like too. So with time, there's definitely more comfort and certainty with both the patients and there are providers who are seeing them based on what they give. But initially, it can be very hard. So the things that are differentiating factors that are helpful for doctors who are seeing patients in the emergency room are, symptoms that tend to be what's called extra symptoms. So instead of can't see something, there's extra sparkles or extra zigzags. Those tend to be more migraine symptoms than stroke-like symptoms. Other things that are helpful are the symptoms are progressive over time, over a few minutes. So stroke symptoms tend to happen and then they can get better or they can stay constant. They tend to not move around or spread or get worse. That tends to be also more common in migraine. But the first time a serious neurological symptom happens, if it's never happened to you, I think definitely it makes sense to get it checked out by someone who knows the difference because these things are really hard to tell apart.
Yeah, there's definitely a lot of overlapping symptoms for sure. Thank you. How can stress, and again, we've already talked about this a little bit, but how can stress lead to heart attacks, and when should we start worrying and changing our behavior and doing things to help ourselves?
Yeah, I mean, it's a huge question. I think we're battling with it in clinic, we're battling with it in research. So I think number one is that I think there's research supporting the fact that chronic stress does increase risk of heart disease, and that's more so in women. So I think there definitely is a sex-specific difference. Number two is that each stressful event can worsen symptoms or can actually cause an event itself. So Kelly told a very classic story of having a stress-induced cardiomyopathy where there can be an overwhelming stress that really sort of overwhelms the heart. It overwhelms some of the receptors in the heart becomes stunned, and then it doesn't work as well, and then slowly over time it improves function. On top of that, we see, and I see all the time, and I think Kelly's seen that pattern, and a lot of my patients have seen that pattern, where if you have small vessel disease, or you have coronary vasospasm, or even if you have a tear in the artery, or even if you have blockages in the arteries that have been fixed, you can have episodes of chest pain that are directly tied to stress. And a lot of my patients say, you know what, my threshold for stress has completely changed. I used to be able to handle X, Y, and Z, and I could do everything, and now I have to really take it in stride, which is I think what Kelly was saying. So I think first of all we need to look more at risk factors for stress and how we handle stress. But second of all, I think people who see that association have to make changes, and it's hard. It's hard to give up things that you love, right?
It is difficult. I was just thinking also beta blockers help.
Yep, beta blockers, which block adrenaline.
Some of the meds help you to stay even, take some of the physiological effects of stress away, and that just helps to stay in a kind of balanced place. So yeah, I would just recommend whenever I come back to the city, I think people do whatever you can to reduce this stress. It isn't good for you. It's not good for us.
And finally, was actually a fascinating study, and it's been replicated, but many years ago, where they looked at this question of stress testing, where what kind of stressors should you use in order to diagnose women versus men. And they actually put people in an MRI machine, and they gave them a physical stressor, and then they gave them an emotional stressor. And you've heard of this, the physical stressor was way more significant for men in bringing out their heart condition, and the emotional stressor was way more significant for women in bringing out their heart condition. So if you actually had a perfect scenario, in women, you would emotionally stress them, and in men, you would physically stress them. The problem is, how do you standardize that? And how do you standardize that in a fashion that can be done in labs across the world, because stress testing is done everywhere. But food for thought.
Super interesting. What is a misconception about women's heart health you hear from other doctors?
Misconception. So, I still unfortunately get phone calls, not that commonly now, because I feel like we have just sort of really tried to change change the way that people think about things, but I still get misconceptions like, this woman couldn't possibly have heart disease as the cause for her chest pain, even though we've, diagnosed her with an actual heart condition such as vasospasm or microvascular dysfunction. They don't believe in some of those conditions, even though there's actually like physiologic evidence behind that. So that's sometimes misconceptions. Other misconceptions for sure are the sex-specific risk factors, where people still don't feel as though they have a significant role to play, and they still don't take that in their history. I guarantee you, most people, if you went into a cardiologist's office or an internist's office, and don't get me wrong, my colleagues are excellent, I'm not saying that, I'm just saying that, when you go into their office, they probably won't ask you those kinds of risk factors. And they should be asked, and the evidence is there. But I think it's a misconception that they maybe aren't as important as asking about smoking or other risk factors.
All right, keeping on the risk factors. How do anxiety, antidepressants, ADHD, all those medications for those affect the heart?
Yeah, so, we've talked about anxiety and stress some, but ADHD, there's certain medications that patients take, and they can be extremely effective. The issue with them is that they elevate heart rate, and sometimes quite significantly. And what I struggle with a little bit in my practice is that a number of these patients also have this dysautonomia that I talked about, where they have high heart rate and low blood pressure. So they're on a medication that's causing high heart rate, they already have high heart rate and low blood pressure, and then it makes things worse. The problem is that they tell me, and I believe this, they can't function without the medication. So therein lies the problem. And so, we've tried to come up with ways to sort that out. We've certainly come up with various medications that can be helpful to lower the heart rate. It feels like you're obviously fighting two things, but at the end of the day, and that's what I ask them, can you live without this medication? I would love you to be without this medication because it's going against what I want to do. And they say to me, I can't live without this medication. I've tried to go off it and I can't. And so then we work around that, and we can find ways to work around that.
Finding the balance, always a tough one. We have another question for you, Dr. Sedlak. You mentioned oral contraceptives are, what does it say? And growing up with pain is a risk factor. I'm not sure what that means, but what % increased risk is associated with symptoms of taking contraceptives while you're growing up?
Certainly Dr. Zhou already talked about the fact that oral contraceptives in the right patient can certainly increase their risk. There's no doubt about it, by 2, 3, 4-fold. If you have migraines with aura, if you have uncontrolled blood pressure, if you have a history of clotting, certainly in patients who had a risk of stroke or have had a stroke at a young age, or who have uncontrolled risk factors, very high cholesterol, diabetes, those types of things. And we try to wean them off their oral contraceptive pill and try to find another sort of local solution if it's for avoiding pregnancy, or if it's for other hormonal symptoms. There can be progesterone-only solutions in terms of getting them involved with a gynecologist. And so we can certainly work around that.
Okay. And I think this is our last question, unless we frantically get on the one here in a moment. I know, but they're fast. They're good. Denise asked, what do women need to get access to cardiac healthcare center relevant to your own clinic? So how would you advocate and press and ask for being pushed to the next level when your doctor is maybe not hearing what you're saying?
I just want to say one thing, for the Women's Heart Center, they can self-referral. We have self-referral first.
Yeah.
So that's
She's saying that you can self-refer to the Women's Heart Health Clinic?
First of all, I really, really still truly believe that you have to have a good relationship with your primary care. So if that's not working out, and I realize we are in a crisis, and we're not going to fix that tonight in terms of British Columbia and general practitioners and not having enough, but you really, truly do have to have a good relationship with your general practitioner. I believe that wholeheartedly, and if it's not working out for you, you got to start looking for somebody else, but you got to have a GP, obviously, as well. So that's the first thing to say. The second thing to say is that go down the pathway of doing some initial testing. But if all of that sort of leaves you with this feeling that, you've got this feeling that at the back of your mind, you still have these symptoms and you feel that they're heart related, and you've tried some things and nothing's working, then you can move further. You can certainly ask for a cardiology referral, you can ask for an internal medicine referral. I've actually had people really try and push and actually reach me, and they've been so happy that they were able to reach me or other cardiologists just because they did push and they did advocate for themselves. But the final thing is that, our own program, we have a nurse practitioner who's excellent, Dr. Parvand, and are hoping to hire another nurse practitioner. They can see patients without a referral. So they can see self-referrals. So we'll often get a self-referral. They'll see Dr. Parvand first, and she has a lot of experience in terms of cardiac workup, and then she, she'll do the initial thing, and if testing comes out and it's abnormal and she's uncomfortable with what to do, then she would refer to me, because she can make a referral to myself or to other cardiologists within our clinic, or certainly she can get into a cardiac rehab program or whatever needs to be done. So, but at the end of the day, I think advocacy is key. I think Denise is right that we have to listen to our bodies, we have to think about, how can we sort of push harder, and ask for things. Ask to get your blood pressure checked, ask to get your cholesterol checked, ask to get an ECG done, and if you have symptoms, ask to sort of push further. And if you're not happy with what you hear, you can push somewhere else, try somebody else.
Great. And I guess a second part to this question is, for those who don't have a family doctor, that's a lot of people though, a lot of people don't have family doctors, there is a shortage, so can you go into walk-in clinics and ask for all these things as well as do the self-referral to the women's clinic?
You can. Again, we're not in an ideal situation right now, because in an ideal situation, people would have a great relationship with their primary care that knows them for years, and that you come in and you say, this is different, and they believe you, and you go ahead. But we're not in an ideal scenario, so I think you have to do what you have to do. You have to go into a walk-in clinic, you have to see a nurse practitioner, because there are nurse practitioners in family doctor's offices as well, not just obviously in a cardiology office. You have to try and push to see, a friend's or a family's a general practitioner. Or if things are really bad, you have to go into urgent care, and they will often refer you on as well. So I think, obviously we need to get care, and however you can get that is important. But the family doctor relationship is key, and without that, it's really tough.
All right, we've got another online question. It's been shown that certain ethnicities have higher stroke risk. Is it due to diet, genetics, or other factors?
Yeah, the short answer is yes. Sorry. I think it's really hard to tease out racial and ethnic differences in terms of what is lifestyle and what is genetic, because we don't get to have the same tools to study them like we do our treatments. It's incredibly challenging to change a lot of the cultural practices. It's easier to recommend, hard to do. So certainly we know that there are certain types of conditions that different ethnicities have a predilection to. Here in Vancouver, like a specific type of vasculopathy that affects one of the major arteries inside of the head, was described in Asian countries and is more common among Asian patients. But here in Vancouver, we've seen it associated with all ethnicities, but our Aboriginal patients seem to have a higher predilection for that condition. And then there's a lot of in addition to the genetic considerations, we do recognize that a lot of dietary changes, a lot of dietary habits are certainly different across various ethnicities, and it's part of the reason why life is worth living. And so when you recommend certain things, a lot of time it's getting buy-in, right? It's recognizing that some change is better than no change, and to figure out what aspects people would actually do in terms of recommendation, and figuring out really maybe culturally specific barriers. Like for example, it's really lovely here in Vancouver, for example, that our Meals on Wheels program, you can try and look for specific types of cuisines and then chat with your patients about what might be components of their meals that are more problematic in a way that's culturally specific. So yeah, the short answer is yes, all of those things matter. And then for us, we need to learn more about what are the genetic causes, and then also specifically the modifiable components that we can work on as clinicians in our day-to-day practice.
All right, so similar but different. What are the differences between men and women with respect to stroke risks, genetic causes, and long-term outcomes?
Yeah, wow.
No pressure, no pressure.
Yeah, so there's changes throughout a patient's lifetime. So like I alluded to before, so one of the reasons why heart and stroke diseases traditionally before was thought of as having a predilection in men is that certainly in younger age groups, so in the premenopausal period, there's was well described a higher age-adjusted stroke risk in men, and that flips after menopause, and women tend to be older at their time of their first stroke, and that comes with a lot of different implications. So a lot of times it means that they're living alone at the time of their stroke, and that could have implications about how they arrive at the hospital and when they arrive at the hospital, and that has huge implications about what their post-stroke care looks like in terms of the amount of support they have available. And so that's one factor. And then we know there's different risk factors impact men and women differently. So yeah, diabetes, especially type 1 diabetes, carries a much higher risk associated with stroke in women. Atrial fibrillation, we know now, learning more about that, we actually take sex into consideration when triaging the risk of stroke associated with atrial fibrillation. When we, family doctors and general practitioners advise on selecting the type of patients that might benefit from being on a stronger blood thinner. And then lastly, I think we need to learn a lot more, as you alluded to, about how our treatments actually impact women, because a lot of the information we have is on research trials that really there's underrepresentation. And some of the work that's we actually did here at Vancouver General Hospital, Dr. Field in the back of the room was looking at some of the reasons why different participants might be approached for research and have reluctances in participating. And there's definitely sex and gender related differences as well. And that needs to be explored more. What are some reasons why women might be reluctant, and is that related to caregiving responsibilities or other concerns about participating in research?
Are your brains full? Yes? All right, I think that is the end of our discussion time, so I'd like to say a big thank you to our panelists again. Mahraz Parvand, Dr. Zhou, Kelly, and Aviva as well. Thank you so much for sharing your personal stories and telling us so much information that we're going to no doubt Google later on and research more about what on earth did I just hear. So we want to thank you once again for joining us virtually and in person today. We want you to feel empowered and take control of your own health and to support the change that needs to happen within the system that we have so we can close the gap in women's heart and brain health. Please remember to drop off your survey forms when you leave. We've got a whole bunch of snacks out there and refreshments. We have time to chat with everybody else that's here and maybe some of the panel about what you just heard this evening. So thank you once again for attending. Don't forget to take your selfie in your gorgeous red outfits and post to social media with the hashtags #HeartMatters and Wear Red Canada. And don't forget to add your heart post-it to the board outside with your reflections of women's heart and brain health and what you're thinking about today and what you'd like to share on the board with all your thoughts. So thank you once again for attending this evening.
Thank you so much, everyone. If you have any questions for us, please talk to the volunteers or myself. And yeah, thank you so much for attending. Hope you enjoyed the session. Yes. Great, thank you. Great job. It was a late. Thank you for understanding. We'd like to do a group photo of the panelists. We'd like to do a group photo of the panelists. Where did Aviva Thank you so much. I didn't have